Okay, hi everybody. I'm Dr. Robert Hauser from the University of South Florida. About a 35-minute drive right up I-75. So thank you, Stu, for that wonderful warm-up presentation. Now I'll go on to build onto that and clarify all the points that were just a little off. He's busy talking. He didn't hear me. Okay, no, it really was a wonderful presentation. Thank you so much. Thank you to Neuro Challenge for inviting me to speak here today. Thank you to the sponsors for enabling such a wonderful symposium. And thank you to all of you for attending today. I hope you're learning a lot, and I'll try to add to that. I have a pretty content-full presentation. It's a little technical, but hopefully those of you who are interested in that will gain from it. We do a lot of clinical trials looking at new medications and new ways of using medications at our center, and I'm going to use that experience to help provide the content for this talk today. So I'm going to talk about recent and future medications for Parkinson's disease. I do a lot of work with pharmaceutical companies. I'm a paid consultant for many of those, and many of the medications I'll mention today I have worked with pharmaceutical companies. So what I'm going to talk about today are recent and future medications that will help maintain motor benefit through the day, and depending on how much time I have, I'll also do a brief introduction to future treatments to slow or stop disease progression. So for those of you who can remember all the way back to 10 a.m. this morning, you may remember Dr. Sutherland talked about in Parkinson's disease, patients are losing dopamine neurons. And in this slide, they're represented by these red arrows here. They deliver dopamine up to the area of the brain we call the striatum. And right at the tips of those arrows, that's where dopamine is released normally. And in Parkinson's disease, patients are losing dopamine neurons. And once about 50% of those neurons are lost and dopamine is reduced by about 50%, patients experience the classic motor signs of Parkinson's disease, including tremor, slow and small movement, and stiffness. And so we'd like to provide dopamine replacement to improve symptoms, but we don't do that. Why don't we use dopamine? Well, it turns out dopamine doesn't get into the brain. We say it doesn't pass the blood-brain barrier. It can't get from the blood to the brain, so we need other treatments, and I'll talk about that. So what do we need to do as physicians, as clinicians for patients? Well, the goal of therapy is to provide the best function and quality of life over time and over the years. And when I make the diagnosis of Parkinson's disease and the patient asks me, how will I do? I say the good news is medications usually provide quite good benefit for the first 5 years for slowness and stiffness. Tremor is kind of a wild card. It may or may not respond. From 5 to 10 years, many patients are experiencing these fluctuations in response, the off episodes that Dr. Isaacson talked about. And even more importantly, 10, 15 years and beyond, many patients are experiencing difficulty with balance and thinking and memory. And I think it's going to be really hard to come up with good symptom treatments for balance problems and thinking and memory. And that's why we and others are working so hard to come up with ways to slow progression of disease. If I could say, geez, patients aren't going to run into balance problems or thinking and memory problems until 20 or 30 years, that would be so much better than to say 10 or 15 years. And again, I'll touch on that a little bit if I have time later on today. So let's move on and think about treatment. So levodopa. So I said dopamine doesn't get into the brain. And so our forefathers in Parkinson's disease treatment had to think about, well, if dopamine doesn't get in, what can we do? And very bright people realized, well, if we can't get dopamine in, how about the precursor to dopamine, and that's levodopa. Levodopa can be turned into dopamine in the brain, and that was quite a revolution and revelation. So levodopa today remains the most effective treatment for motor features of Parkinson's disease, but as you heard from Dr. Isaacson, its use is associated over time with the development of motor fluctuations. And we say when a patient is on during the day, the patient's getting a good response with regard to slowness, stiffness, maybe tremor, mobility. And when the medication benefit wears off or is yet to kick in, we call the patient off. And that's a return of Parkinson's symptoms the slowness, stiffness, tremor, immobility. And the reason that occurs, and again, Dr. Isaacson hit on this, in part is because levodopa is a very short-acting medication. It's very short-acting in the blood. And here on the screen, you see once it gets absorbed in blood, it's rapidly absorbed, it rapidly reaches a peak, and then it's rapidly cleared. And it only maintains a good level, what we call a therapeutic level, or a level good enough to provide good symptoms, for about 2 hours or so. So a very short time. And by the way, the carbidopa is there just to prevent the peripheral conversion of levodopa to dopamine, because when that happens, it causes nausea and vomiting. So the carbidopa is really there to reduce nausea and vomiting. It's the levodopa that provides benefit. And as I just said, it really only maintains good levels for about 2 hours or so. And as you heard again from Dr. Isaacson, that levodopa's got to go down the esophagus. It's got to get past the stomach. Can't get absorbed from the stomach. It's got to get into the small intestine, labeled number 3 here, get absorbed into the blood, and then go to the brain, where it has to find its way into remaining dopamine neurons, get converted to dopamine, and then hopefully stored and slowly released over time to provide good benefit. And in fact, that works in early Parkinson's disease. Doctors commonly give carbidopa, levodopa 3 times a day in early disease, 7 a.m., noon, and 5 p.m., something like that. And benefit is lasting 5-6 hours. Patients say, "Great job, doc. My slowness, stiffness, tremors improved. Medications lasting from dose to dose." But as time goes on and patients lose more dopamine neurons, that storage and release capacity diminishes. And then patients say, "Hey, doc, my carbidopa, levodopa, it seems only to be lasting 4.5 hours. Then it wears off. And the slowness, stiffness, tremor comes back. And then it's 4 hours, and then it comes back. And over the years, then 3.5 hours, then 3 hours. So that benefit becomes shorter and shorter over the years. And in addition, again, as Dr. Isaacson mentioned, Parkinson's also affects the nerves to the gut, so the stomach's not working as well. It doesn't push the medications through as well to get to the small intestine, labeled number 3, to get absorbed. So it may take a longer time for the medication to get absorbed, and it becomes more variable. And so those two effects together make patients experience more commonly and longer and more variably those off episodes. So how do we then come up with ways to smooth and maintain a good response through the day? Well, we need longer-acting oral carbidopa-levodopa formulations. We can consider whether we can deliver carbidopa-levodopa more continuously through the use of infusions. We can add boosters that make the levodopa effect last longer. And we can utilize as-needed treatments when an off episode occurs. And I'll talk about these now. So what about longer-acting oral carbidopa-levodopa formulations? And by the way, that figure there, that's not coronavirus. That's a molecule of levodopa. That's what levodopa actually looks like if you get up real close. All right, so that's levodopa. So we have approved a longer-acting levodopa, carbidopa-levodopa called Rytary. All these medications have 2 names. This is carbidopa-levodopa extended release. Its trade name is Rytary. These are capsules filled with little beads that contain carbidopa-levodopa that get absorbed at various rates to allow this absorption from the gut over a longer period of time. They're designed to achieve therapeutic levodopa levels as quickly as regular carbidopa-levodopa or Sinemet, but to maintain that therapeutic level for a longer period of time. And so here's what it looks like in the blood. I guess this works. So if we look here, if we look here at the burgundy, we see regular Sinemet or carbidopa-levodopa IR is rapidly absorbed and then rapidly cleared. And we can compare that to Rytary, rapidly absorbed, but notice that it maintains a good therapeutic level of levodopa for much longer time, maybe 5-6 hours before it's cleared. So Rytary maintains a longer, higher levodopa level. And when we tested it early on in patients who were experiencing fluctuations up and down, what we saw was that if regular carbidopa-levodopa IR lasted 3 hours, Rytary lasted about 4.5 hours. So that was quite encouraging. And then when we went on to do a phase 3 study, these are the final studies that are presented to the FDA for approval, I'll tell you what we saw, but just to give you the background, when we do these studies, we look for patients who are experiencing at least 2 or 2.5 hours of off time per day, but when you look at them as a group, it turns out they're actually experiencing about 6 hours of off time when they go into the study. And what we saw was that Rytary reduced off time by 1.5 hours more than regular carbidopa-levodopa, even as patients took Rytary on average 3.6 times per day, compared to regular carbidopa-levodopa, which patients took 5 times per day. And on that basis, Rytary was approved. And if you're interested in how this works, tell you what, let's do this, guys. Test, test, test. And if you're interested in how this works, here's regular carbidopa-levodopa IR. I said it's rapidly absorbed, reaches a peak, and is rapidly cleared. This is 100 milligrams. If we look at a similar dose of Rytary, well, its shape is different. It gets rapidly absorbed, but it's kind of squished out like this, so it lasts longer. But notice it doesn't get up as high. To get a similar benefit, we need to get the concentration up higher, so we got to give more. Here's 2 of the 95s. Here's 3 of the 95s. So the general rule that I use is we have to use for a single dose 3 times the dose, but we can administer it 2/3 as often. So in general, patients need about twice as much through the day, but we're filling in those troughs. And so as I said, we give 3 times each dose, but administer it 2/3 as often because it lasts longer. Now the key of using Rytary is the physician has to know how to use it. You just heard me kind of stumble a little bit through this conversion process. So they have to know how to do the conversion, and when the patient is converted, they have to give feedback to the doctor. The dosing conversion might be a little bit low, a little bit high, so we say it's very important for the doctor to get feedback. If you're too slow and stiff, the dose has got to go up. If you have some dyskinesia, dose has got to go down. So we teach this to physicians to help them successfully convert patients over to Rytary, these patients who are having fluctuations and off time. Okay. So I said that Rytary lasts longer than regular Sinemet, but wouldn't it be nicer to have an even longer lasting oral carbidopa-levodopa? And the answer is yes. And the makers of Rytary are actually working on a drug that might last longer. This is in development. You see that in the blue cloud there. And the experimental name of this drug is IPX203. And if we look here, this now is not blood, but how patients are doing, and good is down. On regular carbidopa-levodopa, you see patients improve for about 2 hours, but by 3 hours, they're wearing off and symptoms are coming back. What about on the experimental drug IPX203? Well, they're improving through 2 hours, but they're staying improved 3 hours, 4 hours, 5 hours, 6 hours. So this looks like a drug that might provide good benefit for 5, 6 hours. So we'll see how this pans out as we do more clinical trials, but this might be the next even longer acting oral carbidopa-levodopa. Stay tuned, IPX203. All right, what about delivering carbidopa-levodopa more continuously through infusions? Well, I met a gentleman over on the side here who has this. This is Duopa, also known as carbidopa-levodopa enteral suspension. Enteral means gut. So this is sometimes referred to in slang terminology as the pump. This is a pump that delivers carbidopa-levodopa right into the small intestine. The pump is connected to a tube that goes through the abdominal wall into the stomach with the tip down in the small bowel to deliver carbidopa-levodopa right where it gets absorbed. And this turns out to be highly effective. Again, when patients came into the clinical trials, they had about 6 hours of off time per day, and the pump reduced that by 4 hours. And when we compare that to regular carbidopa-levodopa immediate release or Sinemet, the pump reduced off time by almost 2 hours, which is quite a large difference. But as I tell patients, there's a lot of maintenance involved. In the study, this pivotal study for the FDA, what we saw was that just in this 12-week study, 24% of patients, you see here with the asterisk, experience tube dislocations. That means the tubes moved, so we have to call the GI doctors to get them back in place. 13% experienced tube occlusions or blockages, and I think it's 18% of patients, there was a pump issue. So this is a highly effective therapy delivering carbidopa-levodopa right to where it gets absorbed, but you have to be willing to do a lot of maintenance, call the GI doctor if a tube gets dislocated or blocked up, and take care of the pump pretty rigorously. So that raises the notion, if getting carbidopa-levodopa into the bloodstream in a nice continuous fashion does a good job smoothing patients out through the day, can we do that in an easier way that doesn't require so much maintenance? So one of the things that we and others are looking at is, what about infusing medication just under the skin? That way, it doesn't have to be so invasive. It doesn't have to go into the stomach. It doesn't require tubes that are deep into the body, etc. So here's another therapy that's in development. This is from a company that was actually called Neuroderm. It's been bought out by Mitsubishi Tanaki. And this is subcutaneous, which means under the skin infusion of carbidopa-levodopa. It's a liquid carbidopa-levodopa formulation. As you see here, there's a relatively small pump with 2 little tubes that the patient puts in under the skin each day. And so it's not as invasive as the Duopa pump. And I've illustrated, or taken an illustration here, patients on regular carbidopa-levodopa. If you look at their levodopa concentrations in blood, they're sort of all over the place, including these low levels when the patient may be off. And if you add the subcutaneous carbidopa-levodopa infusion, you get rid of those troughs and maintain nice carbidopa-levodopa levels. And in their study, what they saw was that patients who had about 6 hours of off time had a reduction of off time of about 2.8 hours, which is pretty good. Side effects with this medication, patients do get some site adverse events, and these can include some hemorrhage or irritation at the site where this infusion goes. And they can also get these what are called nodules, which is kind of inflammation and sort of a hard, rubbery feeling under the skin there. So the company and other researchers are working on ways to try and reduce those, and we'll see how that goes as it makes its way through additional studies. There are other infusions that are being studied. They're earlier in the development. One comes from AbbVie, which is actually the maker of that intestinal pump. They're using the prodrug, which again means the medications that are turned into carbidopa-levodopa, in a similar infusion under the skin. That looks interesting. We'll see how it goes. And Dr. Isaacson also alluded to a different kind of medication, apomorphine, which I've labeled here as levodopa-like, meaning it has probably as good effect as levodopa, but it doesn't have to be converted to dopamine. It actually acts like dopamine in the brain. And apomorphine infusion has been available in Europe for a good number of years, and now it's being studied in the United States. Again, it's an infusion under the skin, and we'll see how that goes as it's tested here. Okay, let's change directions. We'll talk about add-on medications or boosters that make the levodopa effect last longer. One was recently approved. It's called istradefylline, or Norians is its brand name. One of its claims to fame is it's a non-dopamine medication. Technically, it's an adenosine A2A receptor antagonist. It's a once-a-day add-on medication, so patients who are on carbidopa-levodopa, we simply add it on to the regimen. They stay on their carbidopa-levodopa. It's approved as an add-on for patients who are experiencing off episodes. And the way this is thought to work is that adenosine is a chemical in the brain that's sort of floating around, but in the motor system, it acts as a brake on the dopamine system. And by adding istradefylline, it kind of relieves that brake. It's like pulling the foot up off the brake to allow the dopamine system to work better. It's like releasing the brake. And in studies where patients come in with off episodes and they have about 6 hours of off time per day, the addition of istradefylline reduced off time by about 1 hour. So this is available on the market for your doctor to use currently. What about safety for istradefylline? Well, discontinuations in the study, discontinuations were about the same as what happened with placebo. The number one side effect was increased dyskinesia. So patients who had dyskinesia might experience an increase, or some patients got new dyskinesia, was 16% or so versus 8%, but only 1% of patients discontinued because of dyskinesia. Other adverse events include, dizziness, constipation, nausea, hallucinations, insomnia, although those were only slightly more than placebo. So overall, istradefylline looks to be very well tolerated, with only dyskinesia as being somewhat different than placebo. Another booster medication, now this again, look at the blue cloud, is in development, but FDA is going to look at this and consider approving it this year. It's called opicapone. Opicapone is in the category called COMT inhibitor. COMT inhibitors prevent levodopa from being metabolized in blood, so they send more levodopa up to the brain over a longer time, and that's what opicapone does. It's given once a day, and in studies, again, where patients had about 6 hours of off time, it was able to reduce off time by 1.28 hours compared to placebo. And again, the most common side effects, dyskinesia, constipation, and insomnia. All right, I'm going to disappear for a second. Stay tuned. All right, here we go. All right, so a new kind of category of medication that Dr. Isaacson alluded to is as-needed treatment. So what this means is all the other medications I mentioned, you take them every day on a regular schedule. The as-needed medications are for when you begin to experience an off episode, you take them as needed for those off episodes. So the first one is Inbrija, also known as inhaled levodopa. It's approved just recently and out on the market. It's indicated for the intermittent treatment of off episodes, and the instructions are to inhale the contents of 2 capsules as needed for off symptoms up to 5 times a day. So it comes in capsules, you load it into the inhaler, you breathe it in, 1 capsule, you reload a 2nd capsule, and breathe it in. And so the claim to fame is that the levodopa goes directly to the lungs, into the bloodstream, and up to the brain. And so notice it completely avoids the GI system and any problems that delay in GI absorption might cause. And in fact, I provided here a picture of concentrations of levodopa. Now this is healthy volunteers, but notice here in red, inhaled levodopa, nice quick absorption compared to the blue. This is the oral carbidopa levodopa. What happens to levodopa in the fasted state? You see the delay, and in the fed state, even more of a delay. So again, demonstrating, at least here in healthy individuals, the inhaled levodopa makes its way into the blood faster. And we went on to do one of those pivotal trials, FDA approval type trials, and what we saw was when taken at the start of an off episode, onset of benefit with inhaled levodopa was seen as early as 10 minutes, and significant improvement was observed at 30 minutes. Side effects, well, the most common side effect was cough. And remember, these are little particles, so if somebody breathes it in, it may cause a cough reflex. We think that if patients breathe it in slowly, they're less likely to have cough, and we advise patients to breathe it in slowly. Additional side effects that we saw, upper respiratory tract infection, nausea, and discolored sputum. Now, another medication in that same category that a patient would take either when they're in an off episode or at the onset of an off episode is that apomorphine. Again, a levodopa-like medication, a medication that looks to the brain like dopamine, is sublingual apomorphine. This is apomorphine in a film that you put under the tongue, and it gets absorbed from the mouth directly into the bloodstream, and you see it illustrated here. This is not currently approved. It's in development, and again, FDA will be looking at this later this year. And in studies, what we saw with this was when taken at the start of an off episode, onset of benefit was seen as early as 15 minutes, and significant improvement was seen at 30 minutes. Most common side effects, nausea, sleepiness, dizziness, and fatigue. And for this medication, you have to find the right dose, and then you can use it. And in the studies, during the dose-finding part, we found that 9% of patients dropped out due to side effects during the dose-finding part, and then 28% of patients did drop out during the 12 weeks during the use of it period. Okay, So here's what I've been through. These are the medications to try and smooth patients out through the day and try to fight those off episodes. We talked about longer acting carbidopa, levodopa formulations. We talked about infusions. We talked about boosters and as needed treatments. Now, Dr. Isaacson got all that applause, so I got to fight back. How many people want to hear about future medications to slow disease progression? Uh-oh, here he comes. Okay, here we go. So a brief look, maybe, at future medications to slow disease progression. So I think Dr. Sutherland touched on some of this early today. So if we look up top here, we see another way to look at dopamine neurons. Dopamine neurons contain melanin, so they look dark here in the brain, and that's the substantia nigra. Here in a Parkinson's disease patient, we see loss of those dopamine neurons. But the other pathologic feature are these, what we call inclusions. These are just things we see in remaining dopamine neurons. Those are called Lewy bodies. And right there in the center, you see this big ball of stuff. And for many, many years, we didn't know what that stuff was. But it was there. But then there was this, what I consider a very big breakthrough. This is the so-called Contorsi kindred. Kindred is a family. Contorsi is a region in Italy. And this family, in this family, 60 out of 592 individuals had Parkinson's disease. Anybody here have 60 individuals in their family with Parkinson's disease? No, okay, so that's very, very unusual. But anyhow, a very strikingly unusual family where clearly there was a genetic cause. And ultimately, a small number, actually, of blood samples were sent to NIH, and NIH was able to identify a mutation on chromosome 4, right here where the arrow is, and they were able to identify that that mutation was in the gene for alpha-synuclein. And at the time, none of us had ever heard of alpha-synuclein, and in fact, today, we still don't really quite know what it does. But shortly after this gene mutation was identified in this family, well, first of all, many, many patients were tested to see if they have the alpha-synuclein gene, and clap if you think we found a lot of alpha-synuclein mutations. Clap if you think we didn't find a lot of alpha-synuclein mutations. Well, you guys are right. It's very, very rare to find alpha-synuclein mutations, but investigators used a stain for the protein alpha-synuclein, and what they found right here was that these Lewy bodies are actually packed with the protein alpha-synuclein. And what that told us was in all the patients, the vast majority of patients with Parkinson's disease, even though they don't have a mutation in the alpha-synuclein gene, there's something going wrong with the alpha-synuclein system, that protein, the protein alpha-synuclein is clumping up and forming these Lewy bodies. And a pathologist named Brock decided to do this. He took the stain and took all the Parkinson brains in his lab and stained them, and then he sort of lined them up from the least amount of synuclein to the most synuclein, and what he saw was it looked like the synuclein seemed to start down here at the bottom and work its way up to the top. Remember, dopamine neurons are here. And then it seemed to later on affect up top where thinking and memory is. That makes sense. It also started here in the smell nerve. And I think Dr. Sutherland mentioned that smell is affected early. So a lot of that made sense. In addition, investigators found that if they took a little piece of a Lewy body, this little alpha-synuclein clump, and put it into either mice or monkeys in the dopamine area of the brain, it would cause a progressive loss of dopamine neurons. So it could start and create a Parkinson-like picture in mice and monkeys. And in addition, I think Dr. Sutherland mentioned there's a lot of interest in whether Parkinson's might start in the gut. If you take a little clump of synuclein and put it into the gut, in this case of mice, you can see this clumping process progress from the gut and go up the vagus nerve, which is the big nerve from the gut up to the brain. It progresses up into the brain, gets into the dopamine area, and then you start to lose dopamine neurons, and then the mice develop motor problems. So again, this process of clumping and progression of clumping can be started just by putting a little clump down in the gut. So very interesting. So that led many people to speculate or recognize that it looks like what's going on we call a prion-like process. And what that suggests or means is that this alpha-synuclein protein kind of folds and unfolds, and if it comes in contact with a partner, they can sort of link together, and then they can't fold and unfold anymore. They're in a sheet. And then what happens is if they come into another alpha-synuclein protein, well, there's a propensity for that then to join this clumping process. And you see here the green, the normally folded up synuclein comes in contact with a sheet, and then it's pulled into the process, and that's called seeding or templating. And these little clumps can move from neuron to neuron, and that may be how this process spreads through the brain, and maybe it starts in the gut and spreads up the nerve and then through the brain. So where does Parkinson's disease start? I don't think I'm going to get into that too much, but there's a lot of interest in, does it start in the gut? Some of our colleagues have shown that when children have viral infections as part of the inflammation to fight the virus, synuclein increases, and that might be a way to get this process started. It might also be possible that it starts in the olfactory nerve, the smell nerve, and works its way back into the brain. So if this is the process by which Parkinson's disease sort of starts and then progresses, it presents some potential ways to fight Parkinson's disease, to slow or stop its progression. And so these are called anti-synuclein therapies. We might find ways to reduce the overall production of synuclein so there's not as many proteins floating around that can join the clumping process. We might find therapies that prevent the clumping. For example, we might find small molecules that could get in between synuclein proteins that don't allow or make it harder for these synuclein proteins to come together and clump up. We might prevent propagation, which means the way this clumping process moves, we might find ways to prevent the movement or propagation or seeding that I showed you of this prion-like process. Or once these clumps begin, the body, it seems, has ways to clear out these little clumps. In Parkinson's disease, it looks like these clearance processes are impaired. Maybe we can come up with ways to improve the clearance of little clumps before they get out of hand or even as it's ongoing. And lastly, we don't know a whole lot about how these synuclein clumps cause dysfunction of neurons and death of neurons, but perhaps we can figure out more about that and find out ways to reduce the toxicity of these synuclein clumps. Well, the therapy that's furthest along that is an anti-synuclein therapy are anti-synuclein antibodies. And antibodies look like little Ys. They attach to various things, and they can be designed, again, as you know, well, I'll skip that. But anyhow, antibodies have been designed that can attach onto small clumps of synuclein. And what they may do is they may attack the synuclein or attach onto the synuclein as these little clumps are trying to move from one neuron to the next. So they may prevent this or reduce this propagation from nerve to nerve. And in animal studies that recapitulate Parkinson's disease, they look to be pretty darn effective. So there's two studies that are currently underway. One is an antibody from Roche, one is an antibody from Biogen. And the way these studies work, we don't have good blood tests that tell us how severe Parkinson's disease is. So the way we monitor Parkinson's disease is we write down numbers for how much slowness, stiffness, tremor a patient has, and we monitor patients with early disease who are not on symptom medication. So patients who are recently diagnosed, not on any symptom medication, they come into the study, they get these antibodies typically once a month in the vein, and then we monitor how much slowness, stiffness, tremor they have, and we're looking to see over 6 to 12 months, is there less clinical progression in patients who are getting the antibodies compared to patients who are not getting the antibodies. This is just another of many anti-synuclein potential therapies that are out there in labs across the world. This is a peptide, or actually a family of peptides that was designed to cap the synuclein clumping process. So what happens here is, let's say there's two synuclein molecules that come together and are starting to form a clump. This peptide, or one of these peptides, is designed to attach onto that little clump and put a cap on it so that when the next synuclein comes by, it doesn't fit onto it very well, and that clumping process is stopped. And here, if you want to look, here is one of these peptides, and you see how it's disrupted this clump. Here's another clump, and here's the peptide that fits right onto it, and it's disrupted the configuration of that clump. So that right now is being tested in animals, and we're trying to figure out how do we get it distributed or delivered into the brain to begin testing. So how do we really get to a cure? Well, we have to be able to test these potential slowing of disease therapies in people, and I want you to make sure that I've adequately conveyed this to you. So this is my idea. Patient gets motor symptoms right here. Without any treatment, those motor symptoms over the next year and a half or so slowly get worse. But there does come a time when the patient will say, geez, doc, I've got enough slowness, stiffness, tremor that I want to start symptom therapy. And once they start symptom therapy, typically they improve, and how they do after that depends very much on how much symptom therapy they're on. So we have a limited amount of time to monitor disease progression right here, and that may be only about a year. Ideally, once patient has the onset of symptoms, they get an early diagnosis, and that provides an opportunity for patients to enroll in a clinical trial testing one of these promising disease-slowing medications. And we look at whether, in fact, the medication does slow disease. This is our opportunity to evaluate the medication over that initial 6 to 12 months. But if the patient waits to visit an expert center till the time that they need symptom medication, we've lost our opportunity for them to participate in such research. We've lost the opportunity to evaluate the medication. So when I see a new patient and they say, geez, doc, I've had slowness, stiffness, tremor for about a year and a half, and I'm here because I want symptom medication, well, they're not right for those kinds of disease-modifying trials. They've missed that opportunity. The other thing that happens is a doctor may see a patient with just very slight symptoms and say, aha, you've got Parkinson's disease because I can see a little tiny tremor and a little tiny bit of slowness. Let's put you on medication like Levodopa. And again, that patient will no longer be able to enroll in a clinical trial. So what I say is, to determine whether new therapies can slow disease progression, patients must join these studies soon after diagnosis and before starting symptomatic therapy. Such patients are a very important resource to help us evaluate promising therapies, and we don't want them to waste that golden year. So, you all have a homework assignment. If you hear of someone who's newly diagnosed, tell them about clinical research. Tell them that these opportunities exist before they go on symptomatic therapy, because we have this problem. How do we tell them if we're not seeing them? You got to catch them before they go on symptomatic therapy. So will you do that? All right. That's your homework assignment. My name is Dr. Robert Hauser. Thank you very much.